Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. As far as what we're going to do today, we're going to talk about anesthesia and the paradigm shift in the way that we would suggest that you start to look at general anesthesia for your dentistry patients in your service in your general practices. So when we are looking at dentistry from a anesthesia standpoint, we've got some real advantages. The main one being that we can do regional nerve blocks. And those nerve blocks can be administered prior to our procedure and allowed 3 to 5 minutes to take effect. And once that happens, that bupivacaine allows us to carry through that whole procedure, no matter what the length, and complete that procedure with the C fibers from the oral cavity totally blocked so that no signal gets to the upper cortex, which is ideal. What that allows us to do is keep that patient at a level of anesthesia that is extremely light versus the level of anesthesia that we may be used to in general practice or that we were taught in veterinary school. Many of us are using anesthesia for multiple things other than dentistry. That blocks are not as easily administered, especially things like the abdominal cavity, the chest cavity, and other areas that may not be quite as effectively blocked as we can do with those regional blocks in the oral cavity. So that advantage allows us the luxury of being able to keep those patients extremely light. And let me qualify what that extremely light plane of anesthesia is. So when we induce a patient, that patient is generally given, and this is not really that important as an individual protocol, but it's just our protocol as far as pre-meds go. We use Buprenex for cats with midazolam, and then hydromorphone with midazolam or without in dogs. And then we induce with propofol. But this is the important part. When we induce with propofol, we only give enough to allow that patient to still have a swallow reflex, still have the ability to actually chew, but lightly. So the patient has that jaw tone that allows us to place the tube, but not to clamp down on the technician or clamp down on the endotracheal tube. So there's a fine chasm there between too light and just right before they get to the point where they're apneic. I get really anxious when a patient gets apneic from induction, as that is the only time during our anesthetic episodes that a patient is even near apnea. And so we avoid that in almost every single patient, and consequently the patient is kept at a plane of anesthesia that is slightly deeper than that, but still not as deep as we're used to in general practice. Our patients, we strive for each patient to have and maintain a palpebral reflex. and we like them to have some jaw tone. Not enough, again, to bite the sensor, not enough to be able to bite down on the operator during the procedure, but once that steady state of isoflurane is maintained, we're able to keep that fairly consistent. We usually use anywhere from half a percentage to 2% isoflurane, and usually that mean or median probably is more around 1% or so. And with that, we also use a breathe right monitor, which lets us have an audible signal that tells us that that patient is indeed breathing at a rapid level, which is one of the main parameters that we use to monitor. We want that patient audibly telling us all the time that it's breathing by that little high frequency beep that we experience every time the patient takes a breath. So that is the basis for our anesthesia. Maintain that low isoflurane concentration, and I might say that doing that with sevoflurane is probably not even an option, because it's in my experience and in the experience of others, those anesthetic planes are very deceiving with that agent, and patients can go from what appears to be a reasonable level of anesthesia to literally jumping off the table. So we like isoflurane because we can maintain that steady state. It's not hard to get to that steady state. Is within a reasonable amount of time, usually a few minutes of induction, and we know that that patient's going to be in a good plane from that point on, and we usually can maintain that plane throughout the procedure. One thing that does happen that is I'm certainly happy for, versus the alternative, and that is when we turn the patient or when we put pressure on other areas like the top of the head maybe to get a little traction to do extractions with an elevator. The patient may feel that, and the patient may move some. They may ambulate when we turn them to do the other side, or they may show some other signs like retroflexion of the neck when we do that. So that's perfectly fine once they're on the other side, as long as those blocks are in. We can maybe give them a little bit higher concentration or a couple puffs of isoflurane and get them back down very quickly and very easily, so that those nerve blocks on the other side, which are already there and in place, will allow us to do the other side without changing much as far as the anesthesia goes. Now, that being said, we use all of the physical monitors, we use all of our human monitors, which you obviously in most cases are doing as well, with blood pressure and end-tidal CO2 and SpO2 and temperature. And in addition to that breathe right monitor, all of the human interaction that we have with checking that palpebral reflex, checking jaw tone, and evaluating the patient overall. So making that as safe as possible. The other thing that does, it allows us to have very, very quick recoveries. And let me qualify that. We will go through a 2-hour procedure, 2.5-hour procedure at that low level of isoflurane, and then when the surgeon's done and the anesthesia tech is ready to clean the patient up and recover it, it's not possible for us to turn that patient off at that time, because generally the patient's going to wake up too quickly and is going to wake up before that cleaning process and drying process has been completed. And so it makes it a bit of a chore for the anesthesia tech to clean that patient up before it wakes up and stands up on the table. So we usually wait. We usually turn them down a little bit while that happens, and then we wait to turn them off until they're almost through with that. And then within 5 minutes or less, in almost every patient, those patients are up and standing as we put them into the cage. So there's no recovery time that is significant, that detracts from the whole time management factor of getting to that next dentistry case. So it minimizes the time between patients. It also allows that patient to go home and have no after effects of anesthesia whatsoever. So keep that in mind. It is a paradigm shift. I do have a student who is now a colleague in the dental college that works at a specialty practice, and the same type of anesthesia is practiced. And one day the anesthesia resident walked by their case and saw that patient breathing rapidly and the heart rate rapid, and proceeded to take it upon himself or herself to increase the percentage of the gas because their perception was the patient was too light. But that's how we like to keep patients in every instance, is breathing rapidly, nice heart rate, nice cardiac output, blood pressure near normal, and that also keeps them very warm. So another thing that I want to point out that's really important that we've done in the last 12 years, I would imagine, is after we're done with the procedure, we clean the caudal oral pharynx really well. First initially with gauze, and then generally with 2 cotton tip applicators side by side to get the majority of the mucus and blood and debris out of the caudal oral pharynx in and around that trachea. And the other thing that we want to do is we want to, especially if we're doing extractions that are maxillary, that get into the nasal cavity or maxillary recess, where that blood can go retrograde back and sit on top of that soft palate, we want to milk that soft palate with our finger, depending on how big the patient is. If it's a large dog, certainly we can milk with your whole finger and be pretty quickly and effectively getting any blood clots or blood beyond that soft palate back into the oral pharynx so it can be removed. Or if it's a small dog or a cat, we generally use, again, those 2 side-by-side cotton tip applicators and just start at that hard palate, soft palate interface and milk that material, blood, hemorrhage, and blood clots back out of that oral cavity. And again, if you have these patients that are small dogs especially that have oral nasal fistulas already, it may not just be blood contents. It may be all kinds of debris that is packed in there over time from that oral nasal fistula being present. So we do that on every patient, even if you use gauze to pack the caudal oral pharynx or some of the devices that are available now. We still strongly recommend that. And we feel that just by doing that, that allows for almost no phone calls from owners that day or that next day, or answering machine messages that say, Sophie's coughing, and she's been coughing since the procedure, which we always attributed to the endotracheal tube being there for an extended period of time. But my thought is, now that we've been doing this for 12 years and not experienced as much of that anywhere near what we did before, I think a lot of that was just material in the trachea that was not cleaned out before that tube was pulled. So to give you an idea about how this works, I have an actual video that I'm going to post to the Vet Dental Show Facebook group and Facebook page, actually. If you want to go to that page and subscribe, you'll see that video that shows you how to do this step by step, from close-ups of a cat trachea within the oral cavity, doing that in the trachea and around the trachea, and seeing how light that patient is and seeing them swallow when we place those cotton tip applicators back there. And then it pans out to the full view to show you what the process is for the operator, the dental technician, and the anesthesia technician as far as manipulating the patient's head and handing off those cotton tip applicators. It's a very efficient and, in my mind, a critical part of anesthesia that we would never allow a patient to wake up with now without doing that. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.